Okay, good morning, everyone. I would like to welcome you all for this session on quality assurance for image-guided radiation therapy. My name is Jean-Pierre Bissonnette. I'm a physicist at Princess Margaret Hospital, and I will be taking you through this course. Would also like to tell you that I'm chairing currently the AAPM task group TG179, which is looking after guidance for CT-based image guidance technologies. I'd like to start this session by polling the audience. I'd like to know who here is thinking of or are recent buyers of image guidance technologies. Just a show of hands. Okay. Any seasoned veterans here? Okay, a few. Okay, very well. Hopefully we'll make this useful for all of you. So the objectives for these sessions are to provide a rationale for quality assurance for image guidance technologies, which will focus on the geometric accuracy of these devices as well as on image quality. Second objective is to understand the technical issues related to commercial IGRT problems and how to address them and what barriers or pitfalls are apparent so far, and to help users to tailor their own QA program according to how the devices are used in your own clinics. So I'll start with a brief introduction, IGRT, what it is, go over a rationale for IGRT, and provide you a quick survey of the equipment that is used for IGRT. And then we will delve into the quality assurance aspect of these technologies, starting with the classic paradigm of acceptance, commissioning, and quality control, and finally end up with some patient-specific QA. So image guidance radiation therapy is defined as the frequent imaging of the patient during a course of radiation therapy, and to use these images to direct the beams towards the target. It is distinct from the use of imaging to enhance target and organ delineation in the planning of radiation therapy. So IGRT, we make images in order to verify the positional accuracy of the patient and not to be confounded with simulation imaging. Okay, so IGRT. IGRT has been used for multiple purposes across users. First, the first and most basic thing that most people do is to improve the accuracy of radiation therapy, where one can verify the target location or QA the patient position and correct this position in order to have a treatment that is concordant with what's on the treatment plan. Other users are analyzing their positioning data in order to find out what would be the specific PTV setup margins that are required for specific treatment techniques, and may end up in shrinking PTV margins, thereby reducing the irradiated volumes and maintaining high dose to the target. And finally, users are also interested in using these images to adapt radiation therapy according to to the changes that they see on treatment, so that they can correct and moderate setup errors, they can assess anatomical changes and address them through a more formal replanning process. There are some arguments against using IGRT, and I will list them here. First of all, IGRT increases the complexity of radiation therapy. And IGRT also reveals new sources of errors that we need to think about and we need to address and correct, which is new for everyone. People are also concerned about the extra dose to patient from some of these systems, and also may add some workload on people that are already strained in terms of time and resources. So here is a slide that shows several of the commercial implementation of IGRT technologies, going from ultrasound to two-dimensional kilovoltage imaging, portal imaging, as well as the CT-based technologies going from KVCT, MVCT, and cone beam CT technologies using either the treatment beam or kilovoltage X-ray tubes. So we'll be starting with portal imaging. Everyone, I believe, has portal imaging in their clinic, and I will only briefly mention the properties of these images. These portal images are very useful because they give us the information of the anatomy of the patient with respect to the treatment beam right off the bat, and can be used for localization of the patient prior to treatment, or verification exposure, where images are required during treatment to have a record of how the beam is being delivered with respect to patient anatomy. There are double exposure and movie loop facilities to help us do our work, as well as some measurement tools. However, this has been addressed in the APM Task Group 58 report that is freely available and downloadable from the APM website. The second technology that I would like to discuss is KV radiograph. Some commercial vendors, such as Varian, offer the 2D perspective, and this falls into this category. So in KV fluoroscopy, we use, again, a kilovoltage X-ray tube in order to form images of the patient. This yields high contrast images that are easy to visualize. We can visualize bony anatomy much more easier than we can with Paul imaging, or visualize implanted markers. So the image quality overall is much better than that of Paul imaging. And the dose also is favorable. We give much less dose on 2D KV imaging than we do on Paul imaging. The image acquisition is rapid, and some of these devices can be used in fluoroscopic mode, providing the real-time movie loop information back to the user. However, 2D KV can be confounded sometimes by rotations and may be difficult to interpret in this regard. And here are some commercial examples shown here, from the BrainLab Accurate system to the Varian and OBI and Elekta XVI systems are both capable of being used in the 2D mode, as well as Siemens solutions that are coming up. This is an example of a more sophisticated system that is being set up in Japan, where 3 X-ray tubes located on the floor, here, here, and here, take images of the patients using image intensifiers mounted on the ceiling. So this is a research device that is being put up, and that is tightly integrated with the delivery system, such that all 3 tubes look at a patient under fluoroscopy mode and gate directly the treatment beam according to the presence of implanted markers that may or may not be within the desired area. So when the marker here, the little black dot here, moves into the red zone, the beam would be turned on, and when it moves out, the beam would be turned off. So this offers a real tightly integrated gating solution that uses direct anatomical information. And I think this is the way to go for integration of 2D imaging and gating technologies. And again, we have here a picture of the more sophisticated system put up by the CyberKnife people. But this time the X-ray sources are mounted on the ceiling, and they look stereoscopically at the patient and using image detectors located in the floor. We're moving on now to ultrasound devices used for image guidance. So as I prepared these slides, there are 3 systems that are commercially available. There is the Nomos BATCAM system that has been going on for a number of years, the Varian Sonoray, and the resonant medical system called Restitue Restore Prostate. So all 3 systems are variations on the theme, where you have an ultrasound probe that can be registered in space coordinates using infrared markers that are seen using infrared cameras located onto the ceiling. So these are examples of the various commercial implementations. So this slide here shows a little bit of the workflow. So a therapist would image the patient using the probe, and the CCD camera would pick up where the probe is within the room, again with respect to the isocenter, as well as what the orientation of the probe is. And the user, the therapist, would obtain ultrasound images that could be displayed and compared with a reference data set, be it another ultrasound data set or a reference CT data set. And this is an example of how this device would be used clinically, where contours extracted from the radiation therapy treatment plan are superposed on top of the daily ultrasound image and provide information to the user that this patient on this particular instance is slightly misaligned, and provide an opportunity to correct the patient position and bring them back into the intended alignment. And there are a number of papers that describe these techniques and are provided here for your reference. The other kilovoltage CT technology I wish to overview in this talk is the Siemens Primaton system, or the CT on rails. So for those people who have large rooms, you can probably put in a CT scanner that can be coupled to your accelerator and provide high quality CT quality images directly into the treatment room, and provide direct comparison with your planning CT and use regular image registration tools. So since the images are similar, they're equally easy to interpret. And again, this is CT quality, so the radon can probably use these images offline and recontour them if need be, and initiate some adaptive strategies this way. The other image guidance technology that is commercially available is the tomotherapy system, which again is a conventional CT with a LINAC mounted on it. So the detector for this system is a little bit particular in the sense that it's essentially xenon filled cavities that are tilted with respect to the X-ray beam, so that the septa of the detectors becomes the build-up material and enhance the signal, or the signal-to-noise ratio, rather, that can be obtained with these systems. It utilizes the treatment beam, but is slightly detuned in order to obtain a lower X-ray energy, thereby increasing subject contrast and usability of these images. And these are examples. I'm not sure if I don't think they display very well here for some reason, but the images on MVCT, on cone beam CT, because the X-ray energy is high, most photons interact with using Compton interaction, and therefore you lose the K-edge sensitivity, but at the same time you gain the density dependencies on the materials. So you leave out all of the beam hardening artifacts that arise from high-Z materials, and can facilitate contouring, planning, and dose reconstruction for patients, for instance, that have hip prosthesis or other high-Z materials implanted into them, like dentures and so on. So the last group of technology that I wish to present is the three-dimensional cone beam CT-based systems offered by Elekta, Varian, and Siemens. So these systems consist of a conventional linear accelerator to which is attached an imaging system which is either mounted orthogonally to the treatment beam or in the opposite direction in the case of the artiste. Now, cone beam CT has this particularity that makes it very different from conventional CT. Here's a cartoon that shows the imaging geometry. In conventional CT, we have a fan beam of X-rays impinging upon a single slice of detector, and the patient is rotated, the system rotates around the patient on a serial manner in order to reconstruct a three-dimensional volume. Whereas on cone beam CT, we use a cone beam of X-rays that irradiates the entire patient simultaneously and will acquire an image using a single rotation of the gantry around the patient. However, the fundamental difference implies different sensitivities towards scatter. In the conventional CT paradigm, scattered X-rays that arise from the image slice tend to escape out of the field of view of the linear array detector, whereas for cone beam CT, scattered X-rays from anywhere within the patient are allowed to some extent to interact with the X-ray detector and pollute the image, if you will. There's also the megavoltage cone beam CT variants that uses the PORL imaging system in combination with the treatment beam in order to yield, to reconstruct volumetric information using the treatment beam. The beauty of this system is that the imaging and treatment beams share the exact same isocenter. The accelerator is, again, adjusted in order to provide a very low dose rate in order to make the doses in the ballpark of what can be obtained with KV cone beam CT, and uses an amorphous silicon panel EPID that is optimized for MV, of course, so that there is some build-up material in order to enhance the signal. Typical acquisition can be from a half rotation of about 200 degrees. Takes about 45 seconds, followed by 2-minute reconstruction time. Typical dose to the patient is 2 to 9 centigrays, so this is not negligible. However, on the plus side, it is immune from electron density artifacts. So, cone beam CT has enables soft tissue contrast visualization at the treatment site. However, does not offer the same quality as diagnostic CT. The patient can be imaged in the treatment position, and the image data sets can be related directly with the isocenter, with the treatment isocenter, the radiation isocenter that we try so hard to measure. These devices, being 3D, are geometrically precise, so they provide information not only in the 3 directions, but also rotation information in the 3 directions, and again can be calibrated to the LINAC treatment isocenter. There are limitations, however, that people need to be aware of. The acquisition is not necessarily fast and sometimes involve a reconstruction phase that further lengthens the time of the procedure. So typically, cone beam CT systems can provide images, volumetric images, from 0.5 to about 2 minutes for acquisition only. And again, I would like to stress that images obtained with cone beam CT are not of diagnostic quality. They are affected by truncation artifacts. Some of the detectors display some lag or ghosting artifacts that can sometimes impair visualization of structures, and certainly do have an effect on the CT number that can be read out of these devices. And also, as we speak currently, the scatter rejection algorithms and devices are limited at best. So scatter is a big problem for cone beam CT, whereas it's not so much for diagnostic CT. So having presented an overview of these technologies, I will go through the classic paradigm for quality assurance as can be applied to these new devices. So just following the guidelines from the APM TG40, one can have a generic quality assurance paradigm that can be applied to any technology. And this paradigm starts with acceptance testing, that is, ensuring that the device that you just purchased performs according to the specifications in the tender. The second step is clinical commissioning. So use this system in a lab world where people can test them, can perform dry runs, and assess how this device performs before implementing it into the clinic, and also ensuring that adequate periodic quality control testing system is implemented to ensure stable, reproducible, and safe performance of these devices. And once all of these 3 items are dealt with, one can deal with the patient-specific QA that arises from for this particular device according to the clinical use that you have back home. So I'll start with a few words on acceptance testing. So the aim of acceptance testing is probably written down in your purchasing contract, is to verify that the equipment that you just purchased meets the specifications that were agreed upon on the purchase. So verifies that all the safety systems are operational. This is when you do your regulatory testing in terms of doses and leakage, NRC or CNSC for the Canadians in the crowd. And typically you follow, once you've done the radiation safety surveys, one typically follows the manufacturer's customer acceptance procedure, and which is witnessed by the vendor or a vendor representative and signed by both parties. It's also at this time that any other clauses that were written into a tender or a purchasing agreement are tested. And once the document is signed, this is when the warranty begins. Acceptance testing can also be a great occasion to establish baseline values that can be referred to when coming to commissioning or quality assurance or quality control tests. So moving on to clinical commissioning. So the aim of clinical commissioning is to prepare the equipment, but also the staff for clinical work using the new technology. So it involves training, and typically in a multidisciplinary format is particularly appropriate for cone beam CT, for image guidance radiation therapy, because the role of the physicist is changing, the role of the therapist is changing, and certainly the role of the radiation oncologist is changing, and it's quite important for all three disciplines to meet and agree on a process that is safe, efficient, and will lead to the clinical objectives that everyone has agreed upon. And it's also at this time that additional safety issues are addressed and comprehensive baseline values are acquired for quality assurance. As for many new technologies, there is no guidance yet for image guidance technologies QA. However, the AAPM TG 179 has been created last fall with the focus on quality assurance for CT-based IGRT technologies. A white paper is in the works and should be published within the next year or so. When going through clinical commissioning, there certainly are clinical factors that are to consider, so that and again, in a multidisciplinary environment. The physicians would be well advised to tell the physicist and the therapist what is the expected accuracy of the image guidance process for a particular clinical process. One may think, for instance, that SBRT treatments may require stringent tolerances in terms of geometric discrepancies, whereas an APPA breast might have different outlook on the accuracy. Also, when testing things out, one must be mindful of the staff workload and to ramp up clinical usage of these devices slowly but surely in order to give everyone a chance to learn the device, to get familiar with it, and also to improve efficacy with it and get faster at doing it and trusting their own judgments. Another factor that people consider is dose, so it would be well advised to have at least a record of what the dose is delivered for the intended imaging techniques for those that use photons. One must also look at resources, the time on the machine, and what staff is appropriate for these tasks. For instance, clinics that involve ultrasound typically try to recruit someone who has some ultrasound experience in order to expedite the learning process and also the reliability of the results. Another factor to consider is the applicability of IGRT for the clinical process. Again, for SBRT, where we have high doses and very few fractions and very tight margins, IGRT would be quite applicable, whereas for palliation with wide margins and clinical markups, IGRT might not be so stringent, although it can be used to yield some important and interesting information. So all this to say that the clinical commissioning should be guided by the clinical context and to have the multidisciplinary team define what are the goals that are to be achieved using IGRT technologies. So just a few salient points on accuracy. When people or new users are testing or commissioning IGRT systems for accuracy, it is usually very useful to compare the accuracy obtained with the new system with an existing process, be it portal imaging, ultrasound, and so on. And there are papers out there that provide A to B comparison of what is the accuracy that can be achieved with the new IGRT technologies compared with an older one. So there are papers out there that compare, for instance, cone beam CT versus ultrasound, cone beam versus portal imaging, and cone beam versus in-room CT. So it's a matter for the user to define what is it that you have in the clinic currently and that you're comfortable with and that you have a good understanding of, and test the new technology against it. So this makes your life much more easy in terms of commissioning accuracy. However, the crux of commissioning, in my opinion, is to perform dry runs using the new technologies, and typically involving phantoms that allow for independent verification of accuracy. So one selects a phantom. Doesn't need to be anything fancy. A lead ball bearing on a cup of styrofoam can do quite nicely in a pinch, although it may lack some orientation information. So people can use either that simple approach or some of the commercial phantoms out there, or just take out random and perform a dry run test where that phantom is treated exactly like a live patient would be. So that phantom would be subject to a planning scan in order to define a reference data set to which the image guidance data set will be compared to. Then the phantom would be subjected to a treatment plan, essentially to define where the lysocenter would be for that phantom. The plan then would be exported to a record and verify system, and which in turn would distribute the information to your image guidance consoles. One would also be well advised to test at this time the remote couch setup, make sure that it works accurately. And also it's at this time that you should have therapists get involved and perform the setup and treatment of the phantom so that they're part of the testing, the dry run test from the get-go, and they get to learn, again, in a multidisciplinary environment with the guidance of physics on how to perform or how to optimize a clinical process. Therapists often have valuable input that can tell you or tell the physicist what shortcuts or what could be potential ways in order to improve the efficacy and how fast the procedures can be done. So their output certainly is welcome. And then the final bit is to take these images and review after registration with the reference data set obtained from the planning scan. So the beauty of performing dry runs is that as a group, you all identify and resolve the problems that the new user may face when implementing image guidance the first time around, and define what would be the clinical workarounds. Okay? So now the third step in this quality assurance paradigm, again outlined by the APM-TG 40, is periodic quality control testing. Again, this is just to ensure that the performance of the device is stable and reproducible. And again, I would like to make a distinction. Quality control, in my mind, excludes specifically those tests that are mandated by regulatory bodies, such as the NRC or CNSC. And these, of course, need to be done no matter what, and should be considered separate from quality control in the context of this lecture. So essentially, when initiating a quality control program on new technology, the user or the person who designs this program should keep asking themselves, what is it that can go wrong, and how can I ensure that this parameter or this process does not? So there is some guidance available out in the literature. As far as quality control testing for IGRT systems, users have been defining areas that are worth considering. First is safety. Second is geometric accuracy, system stability, image quality, system infrastructure, and DOS. Okay? In the interest of time on this workshop, we will only have time to look at safety, geometric accuracy, and image quality. And this paradigm has been described in a book chapter that I co-wrote in Jake Van Dyke's book, The Modern Technology of Radiation Oncology. So let's start with safety. When considering the safety component of your quality control program, your safety bit should look at testing all of the interlocks, such as all the touch guards, all the motion detectors, make sure that they're functional. It has been reported to me from a user that sometimes the robotic arms of a system can sometimes drift out of position and may collide, maybe due to some manipulation, undesired manipulation, and may hit the couch in some way, shape, or form. So users would be well advised to test that these motion detectors are working on a daily basis before putting a patient on the couch. And again, these interlocks are not only address the touch guards, but or the collision detection devices, but also are the door interlocks working? Is the KV source arm deployment interlock working properly? The flat panel arm deployment, and test again that the terminate key is working properly. Users are also well advised to have a visual inspection of the device before starting today. Make sure that if there was a service intervention the night before, that there's no wires or covers hanging out. And again, to test all relevant radiation monitors. So this is the header of a paper that was published in JACMP from Jörg Lehmann that outlines nicely the safety features that people should consider when implementing a new IGRT device. Now, in my opinion, the dimension of quality that new users should be particularly wary of is geometric accuracy with image guidance systems. Essentially, it means, is the reconstruction isocenter coincident with the treatment isocenter? And this is a cartoon to show a little bit what is happening. So let's say that we have an object that we wish to image using the image guidance system. The image guidance system naturally will tell us the position of this object with respect to its reconstruction isocenter. However, we are interested in knowing where that object is with respect to the LINAC radiation isocenter, and if it's the tumor, we certainly would like to have it at the isocenter. So there has got to be a way to find a mathematical relationship between the image reconstruction isocenter and the treatment isocenter that we're interested in. So with an overview of the literature, we can find that there are two basic methods to ensure coincidence of the image isocenter with the radiation MV isocenter. There is the direct method and the indirect method. In the direct method, the user places an object directly at the radiation isocenter and takes some careful time and manipulation to do that. And once an object is clearly aligned with the radiation isocenter, one can calibrate the image guidance system against that object directly. So one of the advantages of this, thank you for handling the doors. So one of the, some of the advantages of the direct method is to burn, if you will, the treatment beam isocenter directly into the reconstructed image data set. And also, because one takes a lot of time placing the object directly at the isocenter, it can provide some millimeter accuracy. However, the unfortunate thing about this direct method is that it takes a long time to perform. A seasoned user may take 2 hours of his day just to perform this this method. I'd like to point out that this talk is being recorded and the slides will be made available on the AAPM website. And I'm also making sure that all the key references are put onto the slides for your future reference, and they will be shown on the website later this fall. The indirect method for coincidence of the imaging isocenter with the MV isocenter uses a surrogate of the isocenter, such as the room lasers, and places a test phantom according to the room lasers and calibrates the IGRT device according to this phantom. So the advantage of this approach is that it takes only minutes to perform, and one can calibrate their system on a daily basis, which is the case for those people using ultrasound for image guidance. However, this method is subject to laser imprecision and drift. As you all know from the AAPM TG40, the expected accuracy of treatment room lasers is of the order of 2 millimeters, and it has been our experience back at the hospital that this is the type of accuracy that we achieve or using daily testing using the indirect method. So some vendors do recommend and do use the direct method in order to calibrate their isocenters, notably the Elekta Synergy system, the Siemens MVCT system, and the CyberKnife. And again, here's a few references to consider that describe in detail how to do it. So this is a cartoon that actually shows this procedure. One starts by placing a high contrast object near the isocenter, as close as to the isocenter as it is. And here the isocenter is signified by these 3 red lines, which are not laser lines in this particular case. But one can certainly align the object to the laser lines to start with. And then portal images are required of this object in order to define its position with respect to the beam edges, telling us where the object is with respect to the intended radiation isocenter. So the user would be taking a series of 8 portal images in the 4 cardinal angles, and by rotating the collimator 180 degrees in order to wash out the joint precision. With this information, these 8 portal images can be analyzed and can return to the user how much motion is required in order to bring the ball bearing exactly at the radiation isocenter of the device. And once this is done, we can perform a calibration acquisition for the IGRT system. In this case, this is cone beam CT. The imaging system will then record and define a function which we call a flex map that shows the apparent motion of the object on the imager as the components, the arm and flat panel of the device flex and torque as the gantry rotates around it. And these calibration flex maps are then recorded onto the hard disk of the system and are subsequently used to correct clinical projections and ensure calibration, that the relationship that I talked about between the MV and image guidance system isocenters is known and corrected for. So again, this is a cartoon showing images obtained for cone beam CT calibration. So these are 4 of the 8 portal images of the ball bearing. The algorithm automatically detects the edges of the beam and defines what the center of each field is. And some of you may see that the ball bearing for this projection is a little bit off. And this shows a bit of a close-up showing how the ball bearing is mispositioned with respect to the field edges and returns to the user how much motion is required in order to move the ball bearing exactly at the isocenter. And this is greatly facilitated by the use of 3 macrometer stages to which the ball bearing is attached to. So when the ball bearing is at the radiation isocenter, one can perform a calibration cone beam CT and extract what we call the flex map. A flex map, again, is a plot of the apparent motion of the ball bearing as the gantry rotates around it, and is essentially a measure of the flexes of each of the components. And this slide here shows plots of the flex map in the 2-dimension of the flat panel array, and with the thick line showing the average flex map, and the thin lines displaying the 95% confidence interval of about 0.25 millimeters. So the flex map can be known with the precision of about 300 microns. So the flex map in the direct calibration method is a plot of the apparent travel of a point as a function of gantry angle. It removes the effect of component flexes and torques prior to reconstructions, and ties the 3D image matrix to the radiation isocenter of the accelerator. So this is an extreme example of a cone beam CT system that has not been calibrated. So the system has no idea of how the system components torque and flex according to gantry angle, and therefore we get a very blurry image with translocated objects that is not particularly useful for image guidance. And this is another example. This is much more subtle, where the flex map of one accelerator was copied and pasted onto another. And I would like to poll one of the audience to tell me which image, if the image on the right or if the image on the left, which one has been produced by a miscalibrated imaging system. There's a 50-50 chance that you get it right. Anyone wants to venture a guess? The right? Why is it the right? There's a catch to it. Okay, well, you can see that there's a little bit of a blur, especially in the fine elements of the image are a little bit blurry. And this is because the motion that we're trying to correct are of the order of a few millimeters. So objects that are of the size of a few millimeters tend to be more blurry. But the one thing that is clearly not evident from these images, but testing will show you that it is a problem, is that the image is translocated. I gave you the answer right off the bat. No one got it. So that this is a very subtle issue. It's not clearly obvious at the beginning, but the image on the right is translocated with respect to the reference data set because, again, of a faulty calibration. Coincidence with MVCT is a little bit more tricky because you need phantoms that provide high contrast with the MV beams that are used. So this is a picture of a phantom that has been developed at UCSF that has been used in order to characterize in 3D the flexes and motions of all the detectors. So any point in an object, as you know, can be has a unique projection depending on the gantry angle. So it corresponds to a unique pixel. So using this knowledge, the UCSF people have designed a phantom, a cylindrical phantom consisting of several high-density ball bearings that project in expected ways onto each projection as the gantry rotates around this object. However, deviations from the expected values are to be expected. Nothing's perfect. So that they built a software release to identify each of the ball bearings and can relate how their flexes and components and orientations are affected by this particular device, and in turn provide a correction to bring using individual analysis of each of the ball bearings, they can bring a correction that can be used by the reconstruction program in order to remove all of these little errors and realign the image data set with the treatment room isocenter. And again, this method gives us some curves that are analogous to the flex map that I just described, that are characteristic of each individual system. Another example of the direct calibration method is one that is used by the CyberKnife. Again, I'm not sure that this projects very well, but this is a picture of a phantom with a square insert that can be used to input first a spherical object that is easy to visualize and plan onto the CyberKnife device, and subsequently can be replaced by another block through which GAF chromic film is installed. And going through the dry run process for this geometric calibration process, the user can analyze the resulting films from this test and assess the intended projection with that obtained or that visualized by GAF chromic. It's a bit of a shame that it doesn't project very well, because on my original slides you could see the blue spots quite nicely coincident with the planned circles. So moving on from the direct calibration procedure, I will now discourse about the indirect method, which is used notably by the Varian OBI system, the BATCAM, and most of the ultrasound devices, as well as in-room CT. So the principle behind this method is to place a phantom, align it with the room lasers, and then test it out using the software. So any phantom can do. Again, a ball bearing on top of a styrofoam cup will do. Variant provides a number of phantoms. There's a cube phantom here that can be used with some ball bearings on top in order to give it some orientation information. There's a marker phantom or anything that will do, and can be compared again with a reference CT data set so that one can assess how the daily images compare with baseline data sets. This this test can be repeated over gantry rotation, and typically people will use a tolerated displacement of about 2 millimeters, plus or minus 2 millimeters. And again, uses the same phantom, either the block phantom or again a ball bearing phantom or anything of the kind, and with a center marker, and this position will be assessed at 0, 90, 180, and 270 degrees. And again, the images of the day, the image du jour, as we say in French, are compared with the reference images. Another test that is recommended is to compare, is to perform essentially the same test, but instead of using X-rays, we use the mechanical pointer. And the projection of the pointer should coincide with the center of the flat panel, X-ray flat panel, to within plus or minus 2 millimeters. Okay. This slide shows, again, a phantom that is built specifically for ultrasound. It consists of an ensemble of objects of known places and positions that can be imaged under ultrasound and can be compared subsequently with a reference CT data set of the phantom, and can be assessed for reproducibility of positioning accuracy. Also, all vendors offer a phantom of this kind. So this is a picture of the Nomos phantom, which is used, displaying in this case the probe with the 3 infrared markers that can be used to correlate the position of the probe within the room, and resulting images showing the ultrasound of the day, with superposed on top of it the contours obtained from the reference CT dataset. So this can be performed on a daily basis. This is fast. It takes about a couple of minutes to do. And again, the Restitut has come up with their own solution using their own configuration of objects within their own phantom. For the in-room CT, in-room CT consists of a stationary gantry, accelerator gantry, where the table is set up such that it can be positioned so that it shares the isocenter of the CT reconstruction using markers, laser markers. So essentially, to test the geometric accuracy of in-room CT, one uses a ball bearing phantom. You see ball bearings all the time in the image guidance. That is aligned, carefully aligned using the reference laser lines, and can be tracked with a CCD camera mounted onto the accelerator for calibration purposes. And once this is done, the table can be rotated to the intended position of the isocenter, and the CT scanner then moves on rails to take images of the ball bearing, and one can use the reconstruction software to assess that the isocenter on both image data sets coincide. It's my opinion that just as dosimetry is checked on a daily basis on accelerators, the geometry of these devices should be checked as well. And here I would like to disclose a commercial interest in this Modus Pentaguide Phantom. This is a picture of the Phantom, and this is a CAD drawing showing the inside. So we have a reference sphere at the center of the Phantom, and some others with rings in order to provide some orientation information. But again, in a pinch, a ball bearing stuck on top of a styrofoam cup will do just as well, and will allow you to make sure that that the image, the position of the ball bearing or the central sphere in case of this Phantom can be known and registered with respect to the radiation isocenter. So typically the way we perform daily QA is to first align this Phantom according to the lasers, to the room lasers, and we then proceed to acquire poral images in the AP and lateral directions to assess the central axis alignment. We then acquire a cone beam CT, and we compare the shifts recommended by two systems, that they should be in agreement, plus or minus 2 millimeters. We designed this Phantom in order to make it useful in the clinic, such that in this QC process, not only we assess the accuracy of the system, but we also warm up the tube. We make sure that we have enough sufficient disk space on the workstation, so that early in the day, so that we don't get stuck with a full overflowing hard drive in the middle of the day with a patient on the table. It tests the remote controlled couch correction, and it can be well integrated in the daily quality control performed by the therapist. There are marks and etchings on the surfaces of this Phantom to allow therapists to test for OBI, to test for field edge, and so on and so forth. And the way that we've been using it is to set the Phantom up with at an offset position with respect to the isocenter. Subsequently, we take our poral images to assess the MV localization. We perform the cone beam CT to assess the localization according to cone beam CT. And we compare the localization, and again, they're slightly offset with respect to the isocenter. And then we test the accuracy of the remote controlled couch by correcting, using the remote controlled couch, the position of the ball bearing, and we take another cone beam to verify the accuracy of the correction. And this can be done using an alternate set of markings. So so therapists only align the cube according to this alternate markers. Oops. So these are screen captures of the daily QC process, where we have a superposition of the reference CT data set with the daily cone beam CT showing a misalignment, an intended misalignment. After automatic fusion, the user can define the required table correction in order to remove this discrepancy. These coordinates are then downloaded to the couch. The couch is transported automatically to this position, and one can perform a verification Cone-beam CT to verify that the correction was accurate. Very similar processes can be done for 2D matching. So here's an example from SUAU where they have their own phantom set up at ISOCenter, and KV images are acquired in the AP and lateral directions. A 2D match with reference images is performed, and the position of the markers is compared with that of the graticule, indicating the center of the image coordinates. The couch shift is applied in order to bring the marker into the intended alignment using the remote shift, and again is verified using the 2D modality. Image quality. Moving on to image quality. Things that are of interest for quality assurance, things that can go wrong, are notably the scale or the pixel size for each of these devices, what spatial resolution or how small an image can be visualized, the effect of noise, uniformity, and also I'll say a few words about CT numbers, although as I pointed out, the differences in the scatter environment with Cone-beam CT doesn't quite make it ready yet for quantitative CT analysis. So again, all of these parameters can be acquired and analyzed using commercial phantoms that are out in the field. And in this talk, I'll be focusing on the CT CatPhan 500 phantom just because I'm more familiar with it. But anything off the shelf will do. These the phantoms can test for the same things I'll be talking about. So the first thing I want to talk about is scale. So scale is essentially making sure that objects that are of a known size or distance apart are imaged and that the images tell you the same distances away. So here I'm focusing on rods that are within the CatPhan phantom that are known to be 5 centimeters apart. And again, the software, we have in-house reconstruction software that will assess that, that distance using the pixels, and hopefully these should be in agreement. Another thing that we look at is uniformity. Going to your uniformity section of your phantom, one can interrogate the images on the pixel values at the center and at the edges of the image, and compare the mean and standard deviation of all of these parameters. Linearity of CT numbers. Again, this is a slice through the CatPhan phantom through the various density objects. There are 8 of them in this particular phantom representing different materials, and can be used to compare the theoretical CT numbers with that of the Cone-beam CT device. And here I show CT calibration curves for a number of our units back home, and you can see right away that even though the curves are straight and linear, they don't superpose very well, and the introducing or changing the scatter condition can in fact shift curves away from each other. So at this point, if people are interested in using CT numbers straight away from Cone-beam CT, I would advise them caution. The CT number are not stable and are dependent on the scatter condition. If people, for some reason, may want to use Cone-beam CT images for planning purposes, they will be geometrically accurate. CT numbers may not be, so I would advise them to use bulk density correction and perform those calculations on these rather than on CT numbers. Another important imaging parameter that we can look at is the spatial resolution. And again, the CatPhan phantom has a set of bar patterns that can be shown and visualized. And from these, one can do analysis of how these can be visualized and extract a modulation transfer function for each of our imaging systems. So again, this was done for a number of our imagers, and we can show that there are some fairly significant variations from one imager to another. However, all should be capable of visualizing objects of the size of about 1 to 2 millimeters easily. For MVCT, phantoms have been designed, again, to account for the high energy beam that is used for imaging. And this is a phantom that has been designed by Moyed Mifton and his group. It's a 20 centimeter diameter cylinder with inserts that have one solid water section for noise and uniformity assessment, and 2 sections with inserts for contrast resolution and bar patterns as well. There's also beads for positional accuracy. And these are images of their test patterns. So here we have the contrast detail slices and the bar pattern slices, those that were designed and those that were, and these are the images obtained with the Phantom. And in their papers, Gaillou and Mifton have reported that 2 centimeter objects can be seen with 1% contrast, and that all of the line patterns larger than 0.3 line pairs per millimeter can be visualized. Again, commercial phantoms have been used for tomotherapy, and here's an example of using a diagnostic tool to assess performance of the tomotherapy image reconstruction, again using contrast detail objects and spatial resolution objects. And Meeks et al. Have reported that 1.25 millimeter objects can be resolved, and objects of up to a few millimeters can be resolved as well, depending on the signal-to-noise characteristics of the image. For 2D KV imaging, image quality can be assessed again using off-the-shelf tools, and here it shows that again an example of the LEADS tool showing again contrast and resolution patterns. Here I'm being told I'm running out of time, so I'll have to speed through things a bit. Is it? Okay, good. So I'll be wrapping up then. So again, phantoms with spatial resolution imaging can be done. Now, IGRT, is it worth it? I'd like to close this session with this graph, which shows a view of our localization incidents that have been reported through our risk management system. Before, the period before, so from 2001 to 2006 and on, where we implemented IGRT, showing a significant decrease in the severity and the number of incidents related to geometry since the implementation, the partial implementation of IGRT. So to conclude, QA programs have been proposed. They focus on geometric accuracy and image quality. And I will stop at this time. Thank you very much for your attention.